Hey guys, I'm back and I come bearing news for our anesthesia trainees that's going to hit the ABA board certification process in the year 2027. So in addition to doing written boards, both the basic and the advanced to become board certified in anesthesia, there's also an oral boards portion of our examination that includes different OSCE stations, basically different stations that observe the hands-on skills that it takes to be an anesthesiologist. Trainees are going to have to be able to identify different patient factors that would make them a difficult mask ventilation as well as a difficult intubation. And they're also going to have to be able to navigate the ASA Difficult Airway Algorithm, which is very valuable in terms of how we work through patients who are going to need to be intubated or are not the most straightforward patients. Now, majority of patients who come in for elective surgeries are very straightforward, have normal airway anatomy, and we're able to safely put them asleep without any sort of hiccups. However, if you are anticipating that the patient's going to be either difficult to mask ventilate or even potentially intubate, you're going to basically come to your first branch point in the ASA Difficult Airway Algorithm. And that's where you're going to decide, should I put this breathing tube in while the patient's awake, or do I put them to sleep in the anticipation that I can use other resources like a video laryngoscope, an LMA or laryngeal mask airway that could help me ventilate. But that's really the first branch point that you get to. For the purposes of this conversation, we're going to go down the airway algorithm for if you decide to put a patient to sleep. Let's say that you were not successful on your first intubation look. The key here is that you do not continue to just do laryngoscopy with the same technique, because every time that you place a metal blade into the airway, you're causing more trauma and more swelling, and that view of the epiglottis and of the vocal cords and the arytenoids becomes more and more swollen and potentially more difficult to get the actual breathing tube in. So just backing up a second to mask ventilation, if you aren't able to mask ventilate the patient with one hand, then the next step that we do is go to two-hand mask ventilation. So you can use both of your hands to really lift up on the jaw and try and bring that tongue forward and open up the airway that way. If that doesn't work, then the next thing you'll use is an oral pharyngeal airway, which is a piece of plastic equipment that can basically bypass the tongue and open up the airway and the pharynx. If those two techniques are unsuccessful, then the next thing you want to do is reach for an LMA or laryngeal mask airway, which basically sits right above the vocal cords, but usually can give you a good seal that you're able to ventilate through that. So after you've tried one direct laryngoscopy where you're just using a metal blade, whether it's a Miller blade or a Mac blade, usually the next step that you're going to want to go to is a video laryngoscope. Now, McGrath has a lot of portable video laryngoscopes that are very common in hospitals these days. There's also glide scopes or CMAX, but that's going to be your next technique so that, again, you're not causing more trauma every time you do laryngoscopy. The other thing you want to keep in mind is that in majority of teaching hospitals, you're going to have residents or trainees who are learning how to do laryngoscopy. And so knowing when to limit their tries and having the most experienced or person who's intubated the most often, having that person step in at an appropriate time can also help mitigate how much trauma is happening to the airway. Another very useful tool, if you're just getting a partial view of the arytenoids and the vocal cords, is using what we call a bougie. That's a plastic piece of equipment that's very thin, much thinner than our endotracheal tubes, that you might be able to just slide right into the trachea. It has a bit of a hockey stick at the end of it, so you can rub that against the anterior rings of the trachea. So even if you don't totally see it going into the trachea, sometimes you have that tactile feedback of running the plastic piece across the tracheal rings on the anterior portion of the trachea that lets you know you're in the right spot. And then once the bougie is in, you can then train track the endotracheal tube over the bougie, and that can be how you intubate somebody. And let's say you've done all of these ways to optimize your intubation, both with positioning, putting somebody in the sniffing position where you put some blankets behind their shoulders, also sort of lift their head to optimize your view. You've used video laryngoscope, but nothing is able to work for you. That's when you're going to want to place your LMA and then potentially even go down the LMA with a bronchoscope and see if you can intubate through an LMA. Now, if you aren't able to ventilate with LMA, you're now down the emergency surgical airway pathway. So you're going to want to prep the neck, do a percutaneous tracheostomy, potentially even have a surgeon in the room that's able to help you out if you end up going down this path. Now, this is a lot of things to take in. And again, this doesn't happen to most patients, but it's a really good algorithm to get to know and really understand what your branch points are, which the first one is, do I want to put this patient to sleep or should I do this awake? And if your gut is telling you that you should intubate this person awake, then you should trust your gut. If you do end up putting this patient to sleep and you aren't able to ventilate, reach for an LMA. If you are able to ventilate but you aren't able to intubate, try and limit the amount of laryngoscopy that you're doing so that you reduce the amount of trauma to the airway, which only makes it harder for the next provider.